Clinical assessment is important in any counseling or human service setting. Clinical assessment usually refers to using assessment tools in these four areas: diagnosis, intervention, monitoring progress, or evaluating outcomes. There are a lot of data collection instruments, strategies, and sources that we can use. Today we're going to focus on the Mental Status Exam, or MSE. Diagnosis and treatment planning is part of mental health services. We use certain tools to gather and record the information that we need and to make sense of that information in terms of what it means for the treatment of the individual. The DSM-5 is the Diagnostic and Statistical Manual of Mental Disorders, and it is in its 5th edition. In the medical world, the DSM-5 is equivalent to the ICD-10, which is the International Statistical Classification of Diseases and Related Health Problems. The Diagnostic and Statistical Manual of Mental Disorders, however, focuses on the mental health diagnoses of the individual. We also use tools such as clinical or diagnostic interviews, which are part of the intake process and part of gathering information for the mental status exam. We gather information using instruments that have proven to be effective in gathering the information that we need and accurate in obtaining that information, but also just our observation, our professional observations. And so a lot of the information that we collect is subjective. However, there are some guidelines that we'll go over on how to be as objective as possible whenever gathering this information. The mental status exam is the psychological equivalent of a physical exam that describes the mental state and behaviors of the person being seen. It includes both objective observations of the clinician and subjective descriptions given by the patient. The mental status exam provides information for diagnosis and assessment of a disorder and interventions or applications for treatment. It provides a snapshot at one point in time, and it provides the opportunity for another provider to determine if the patient's status has changed without actually having previously seen them. So this is a tool that can aid in continuity of care by having similar language and describing different aspects of a client's behavior and mental state, and across all the different services that they are receiving. Mental health professionals can use common language to determine whether someone is progressing or staying the same or possibly decompensating. To properly assess the mental status exam information, we need information about the client's history, their background, and we also need to take into consideration cultural and social factors. It's important to ascertain what is normal for the patient. For example, some people always speak fast, and so we want to make sure that we don't make any judgments without having some idea of context for placing a person in a certain category or labeling them. Some of the areas of the mental status exam that we're going to learn how to assess is appearance, speech, actions, mood, perception, and thoughts, thought process, and content. The mental status exam assesses all the major systems of psychological functioning. The first thing that we want to talk about is appearance. What do we see? Is it consistent each time that we see the client? What I have on screen are two pictures of Leonardo DiCaprio. On the picture on the left, we would describe this as a neat appearance. Very well groomed, well dressed. It looks like his activities of daily living are all functioning at a high level. The picture on the right would be considered disheveled. If someone looks like they're not well groomed, not being able to keep up with their personal hygiene. Now, what is important to note is if someone comes in looking like the picture on the left 1 week and the picture on the right a few weeks later, that might be a red flag because it's not consistent behavior. Whereas if someone presents the same week to week, that might not be as much of a red flag because it's consistent. So consistency is really important. Consistency in appearance or behavior is not always a red flag, even if someone looks a little disheveled or unkempt. Some descriptive terms that might address behavior are slow movement or unintentional movement, restless or agitated, or any type of unusual behaviors, mannerisms, or gestures that are worthy to comment on. Anything that wouldn't be worthy to comment on would be considered normal or within normal range, which means that we don't all act the same, we don't all have the same behaviors or appearance or speech patterns or thought processes, but we all function within a range that is considered normal. Attitude. What is the attitude of your client? Are they cooperative, friendly, attentive? Are they defensive or hostile, guarded? So what is the attitude that you're currently assessing? Again, this is a snapshot, so this doesn't mean the person's overall attitude is hostile. This is just one point in time, and the mental status exam will be constantly assessed over the course of treatment. And so what makes that really interesting is that over a longer period of time, we can also match up what types of symptoms were presenting whenever there were certain things going on in this client's life that maybe they're disclosing in counseling. Someone may present as hostile because they just got served divorce papers and they're really angry about a lot of things. So we have to look at it in the context of what's going on for the client. But it's just important to note what the psychological functionings are. Affect and mood. So mood deals with, is the person sad, angry, depressed, happy, anxious? And then affect deals with their emotional responsiveness. So if we think of counselors and human service individuals having to have emotional intelligence, that means that we're able to view another person their face and their expressions and their body language, and we're able to understand or probably gather a really probably educated guess as to what's going on with them, what they're feeling, what they're trying to communicate through their body language. And so some descriptive words that might address affect are blunted, meaning a decrease in emotional expressiveness, a flat affect, which is virtually no expression, constricted, which is normal but with some restricted range, inappropriate, meaning that the emotions that are expressed are not congruent with the way that their affect is presenting, their emotional responsiveness, nonverbal behaviors, facial expressions. So someone could be really sad, but smiling and laughing. And this is not congruent. Or crying while smiling and laughing. Laughing at inappropriate things, like traumatic events that happen to them. So things that aren't congruent, we want to make sure that we comment on. And labile, which is unpredictable shifts. So it could go from being very emotionally expressive to a totally flat affect. So back and forth kind of shifts that are really unpredictable and not really congruent with the content that's being shared. Ultimately, regardless of what we describe as the person's affect and mood, we want to make sure that we comment on, is it congruent? We're not saying that one mood or affect is better than another. Everyone has a different way of presenting, but we want to make sure that we're definitely commenting on, is this congruent with what is being expressed, the context of the information that I'm getting from this person and their situation. And we can make a note that it either is congruent or that it's not congruent. Speech has three components. The quantity of the speech, how much someone is talking, how many words are they saying, the rate at which they are saying it, so are they saying it really fast or are they communicating really slowly, and the quality of what they're saying. Are they saying things that are relevant, or are they talking about a lot of things that aren't even related and maybe you can't follow? Client's perception. We want to describe any hallucinations if they're present. Hallucinations typically come in one of four areas. Auditory and visual are the most common. That's hearing things, hearing voices or noises that aren't there. Or visual, seeing things that aren't really there. Auditory can be hearing voices, but I had a client one time who described a static kind of that she heard, and she couldn't make out exactly what it was, but described it as an auditory hallucination that she suffered from. Olfactory is smelling things that aren't there, and tactile is feeling something that's not really there. So another client that I had one time expressed she believed part of her hallucination was that she believed that the government inserted something into her skin, a tracking device, and she could feel in her arm something that wasn't there, this tracking device that she believed that for her was very real, that it was there. So hallucinations can come in all different forms, and we just need to make sure that we're aware of those hallucinations and get an an understanding of what they are and how that person experiences that. Thought is very important. This is where we assess homicidal or suicidal ideation, which may or may not be related to hallucinations as well. But the thought process is how do the thoughts happen? How does the thought process happen for this person? So do they have racing thoughts that they can't even keep up with? Sometimes they're thinking so fast that they can't even keep up with their own thought process and maybe forget things. Not because their thought process is slow, but in fact because it's too fast. Flight of ideas is rapid shifts. This is kind of hard to describe until you see it happen in front of you. I found myself only ever describing one client as having a flight of ideas, and that is this client. I literally couldn't keep up with the storyline. It was seemingly disconnected to me, but to this person it made a lot of sense. They talked in normal speech patterns, but I just couldn't understand the connection of ideas, and there was kind of a shift in the stories and in the way that they were being told. So again, hard to describe until you actually experience it, but just consider it kind of shifts that you can't keep up with. And tangential is kind of talking about things that are, or thinking about things that are not related, a wandering or a lack of focus. Again, we need to assess these things in the context of the person and what they're experiencing. So this may be actually a common experience for someone who has been diagnosed with attention deficit disorder. Maybe they're not able to focus, or they find themselves, their mind wandering. So we need to always keep that in mind. A normal thought process is typically defined as logical and linear, coherent, and goal-directed. An abnormal thought process is typically defined as associations that are not clear, organized, or coherent. Thought content refers to the themes that occupy the client's thoughts and perceptual disturbances. So this can include preoccupations, illusions, hallucinations, being out of touch with reality, depersonalization, or delusions. Preoccupations can be suicidal or homicidal ideation, or obsessions or compulsions. Hallucinations are false sensory perceptions. Depersonalization is a sensation of unreality concerning oneself or parts of oneself. Delusions are fixed, false beliefs firmly held in spite of contradictory evidence. An example of that I gave is the idea of one of my clients who believed that she had an implant from the government that was a tracking device. That would be considered a delusion. Orientation refers to one's awareness of person, place, and time. Memory refers to one's ability to recall information. Memory can be impacted by traumatic brain injuries or trauma, and so we want to make sure that we comment on that if we see any type of memory deficit. We also want to make sure that the information and processing is appropriate for the developmental age of the individual. Finally, we want to assess the individual's judgment and insight into their own life and their own situation. So their self-awareness, how is their ability to be self-reflective and introspective, can they grasp abstract concepts, and how do they react in social settings? Are they flexible or inflexible? Do they have social skills that are within the normal range? And also their emotional intelligence. Are they able to understand others' emotions and social cues? Are they accurate in reporting the information? So if they're reporting information and it's different from what we're picking up or what other people are telling us about this client, then we need to also make sure that we document that. During the course of the normal interview, most of the information relevant to this mental status assessment is obtained indirectly. Remember that many of the aspects of the mental status exam are extremely subjective. There's a tremendous potential for our own cultural exposure and background to have influence in these assessments. There's a major distinction between different and abnormal. People are different in a lot of ways, and that doesn't necessarily make them abnormal. Whenever we're documenting the mental status exam, we want to comment on things as being not remarkable, meaning it doesn't warrant a comment, or it's within normal limits, which means that, yeah, it could be a little different than somebody else, but it's acceptable and it's normal for this individual person.